The Georgia Trauma Commission was established in 2007 by Senate Bill 60, and it serves as the accountability mechanism across the entire state of Georgia for the trauma system to oversee system development, quality outcomes, and the distribution of trauma funding. On this slide, you'll see in the beginning of 2007, you will see that there was over an hour service area in 2007, but you see in 2025 that we have closed that gap and we continue to grow the system to close that gap up. The next slide shows the proposed FY27 budget, and we do not have any additional ask in that. I think it skipped some slides. Yeah, some slides are off of here. I think you have more in your packet. I'm not sure what happened there, but I'll just go along with your packet. The next slide is the Stop the Bleed initiative. And in 2017, we had a goal to have Stop the Bleed kits in every public school in the state of Georgia. And we are 99% complete with that project. And we are, fund that through our system development budget. We continue to grow that budget and expand that initiative as well. And on your slide, there's a couple of patient stories that demonstrate how this readiness can save lives. And these outcomes often begin before a patient ever reaches the hospital. In the first case, it was a life-threatening pediatric injury triggered by immediate bystander recognition, rapid EMS activation, and coordinated trauma care across multiple facilities. That early action and system coordination resulted in survival and continued recovery. In Chad's case, a catastrophic hemorrhage occurred during a violent assault, and immediate bleeding control actions and coordinated trauma care led to successful surgical reattachment. So these cases just show the importance of the Stop the Bleed principles, including early action and hemorrhage control and coordination. And now to the slide that is on the screen. This is the FY27 proposed budget. You are also provided a one-pager that went into detail, line by line on that. You'll see approximately 70% of the funding goes to the trauma centers directly. And then EMS is the other high percentage at 17%. The remaining funds go to development and operations. The majority of the funds are directed to the frontline readiness, ensuring trauma centers and EMS are prepared around the clock. And in the FY27 Governor's Report, line 38.15, the reduction just shows the reduction for the state health benefit plan, which is across the board. And then the increases show the Super Speeder Trust funds to reflect 2025 Super Speeder collection, and then the increase in funds for the FY25 driver's license reinstatement fees. By statute, the Super Speeder revenue goes directly to the trust fund, and then the reinstatement fees is part of the state funds. And we want to thank you for the continued support of the $4 million that is in the base budget. The Trauma System Stabilization Plan addresses ongoing financial pressures facing the trauma center. It provides a predictable readiness cost offset that allows centers to plan more effectively for fiscal challenges. And this plan also allows for system expansion through startup grants for candidate centers without affecting the centers that we already have in place, so it doesn't affect that funding. And importantly, it increases for rural centers while minimizing the impact that it has on the level 1 and 2 centers. The next slide shows how the $4 million impacted by level for FY26. We went from 5% to 8% for level 1s and 2s, but you will see the biggest impact for the level 3s and 4s. For 3s, it went from 4% to 8%, and then for level 4 centers, 31% to 50% of actual readiness cost funding. And that is all I have, and I will be happy to take any questions.
Thank you. I don't see any questions. We appreciate your presentation. Thank you very much for sharing it with us. Next, this completes our various agencies that we're going to. We're going to start on our public comment, and we appreciate all of you being here. There are quite a few of you, and the hour is getting late, so I'm going to ask everyone to please be very succinct and very brief. Make your points as quickly as you can. I'm not trying to cut anyone off, but we do have a lot of people that want to speak today. And our next speaker will be Jeff Beck. If you could come to the podium, please.
How are y'all doing today? Thank you so much. My name is Jeff Beck. Chairwoman Taylor, thank you so much for having me. Thank you to the committee. I'm a licensed clinical social worker. I founded a company called Answers Now nearly 10 years ago after first seeing firsthand how overwhelmed parents of kids with autism were in my work. Answers Now pairs families directly with what's called a BCBA. In the last 10 years, we've served over 3,000 families across 10 states, have delivered about 250,000 hours of therapy. Today in Georgia, we're serving over 300 kiddos, about 80% of whom are on Medicaid, in communities ranging from Thomasville to Hazelhurst, where options are often very limited. One of the benefits of being a fully virtual provider is that our therapy is recorded. It's stored in a HIPAA-compliant cold storage, and we do this to leverage the data to increase quality, but also to ensure there's no fraud, no waste, and no abuse. I want to focus on one specific area where Georgia has a meaningful opportunity, which is caregiver training. National industry data and Central Reach, which is the largest platform for ABA data, shows that providers on average provide about 50 minutes of parent training per month, compared to about 100 hours of direct therapy. That imbalance really matters. The research is clear. When parents are trained to implement strategies during everyday routines like meals, transitions, bedtimes, outcomes improve significantly. A 2023 meta-analysis in the Journal of Autism and Developmental Disabilities reviewed 51 studies and found that parent-implemented interventions produce stronger gains in communication, social skills, and behavior compared to child-only treatment. I want to be clear, the request is not about increasing total therapy hours. In fact, when training is done well, it often reduces the reliance on higher volume care. This is about shifting the emphasis towards the component of treatment that has the strongest evidence for long-term stable generalization of skills. Currently, Georgia reimburses caregiver training at $52.80. That rate is meaningfully lower than all but 2 states in the United States. For direct therapy with the same provider type. We respectfully ask that Georgia considers aligning that rate more closely with the direct therapy reimbursement, specifically increasing it to $105.60. Even at that level, Georgia would be right around the national average. We defer to the state agency, but our own calculations suggest that this would require a total investment of less than $700,000. By adjusting this rate, providers would be appropriately incentivized to no longer prioritize direct therapy over this caregiver training. And even though research suggests that stronger caregiver involvement produces better outcomes, this rate would reflect the need to get those parents involved. Not about expanding services, it's about aligning incentives with what evidence shows works best for these families, empowering families so children can make faster, more sustainable goals. Thank you so much for your time, and welcome any questions.
Are there any questions from the committee? We don't see any. Thank you very much.
Thank you so much.
I appreciate your presentation. Next, Chairman Mathiak, do you want to come forward?
Thank you, Chair Lady and committee. I so appreciate being before you today. And this has been a long haul for us with Duchenne's, and I'm just excited to be here. In December, the U.S. Department of Health and Human Services added Duchenne's muscular dystrophy to the recommended uniform screening panel you had talked about some of the screening panels earlier today, so I'm proud that we've finally made it. In January, DPH, the Newborn Screening Advisory Committee, voted to approve a 3-year pilot program for Duchenne's here in Georgia. The cost of the pilot will be about $1.7 million, and the detailed handout is on your desk. I think you've already gotten that. I have long supported the parental project for MD and its efforts to add this newborn screening panel, and I hope the committee will consider adding this important funding for the children and the families of Georgia. Somebody's here from the department that can go over the numbers with you a whole lot better than I can. Okay. So if you would like, if there's some questions about that, I would ask you to invite them to help me.
Does anyone have any questions? I know you have submitted them in writing, so we do have the numbers.
And I'll
here.
submit this in writing to you as well, Chair Lady, so that you'll have that.
Thank you. We
Okay.
appreciate it.
Thank you so much.
Next is Andy Lord.
Good afternoon, Madam Chair, members of the committee. My name is Andy Lord. I'm here on behalf today of the Sickle Cell Foundation of Georgia. First of all, I would like to thank this committee for the year in, year out ongoing support that you all have already rendered. We are very grateful for it. A quick recap, as you all know, you all have previously funded for us a mobile health unit. We have screened over 110,000 Georgians with our mobile health unit that you all funded, and we have detected over 11,000 cases of sickle cell disease with that. You all may also recall that with prior funding that you all have given us, we have funded 6 brick-and-mortar satellite centers in Georgia. These are typically the population centers. We have one in Macon, Savannah, Augusta, Covington, Columbus, and Hinesville. These are all areas where we have partnerships with FQHCs or other healthcare facilities that already exist in those communities, and we bring patients there. The other thing we use the mobile unit for, we put what we call a traveling hematologist that is funded with the state dollars that you all have awarded us prior. We put a traveling hematologist on that mobile health unit, and it goes into areas of Georgia that are 80 miles or greater away from a brick and mortar health center. So what we have is something like the old hub and spoke model a little bit, where we have physical centers and the population centers and a mobile unit to go into some of the more rural areas. I do have available to any of the committee members a full report, a 2025 report, of all of our accomplishments, the number of Georgians we have seen. We had a physical presence last year in over 100 Georgia counties. This year, as you will see in your in the budget request that we've submitted to the committee, we are requesting an additional $561,000 for our budget this year. I want to emphasize with the committee that this was the amount that you all funded us at last year. This budget proposal in front of you is almost entirely a repeat of what we brought last year and that you all fully funded. Unfortunately, the Senate was unable to fulfill any of you all's budget. So our budget request that you all were so gracious with us with last year was fully zeroed out. Senate was not able to fulfill it. We are back with what is tantamount to the same budget request. There are some minor tweaks with regard to where we are directing these dollars, but it is still the mobile unit, it is the wellness center, it is the satellite centers. We've also done extensive physician training. We have added mental health services to our wellness center. What we know is that patients and families often really struggle when they're dealing with this painful chronic disease, that we have mental health issues as well. Again, as you can see, this is for hematology care and patient navigation. Part of this budget request is for mental health support. That is one of the deviations from last year. And then, of course, small budgets for the marketing, patient outreach, and the technology infrastructure. So we want to thank you all again for your previous support. We are hopeful this year that if this committee gives us the same support that we got last year, that we will have better luck in the Senate, and we've already begun working on that process. So that's all I have, Madam Chair.
Thank you. Are there any questions from the committee? I see no question. Oh, I'm sorry. Dr. Owen?
Andy, thanks for coming to present. Quick question about the screening. You said you caught 11,000 patients in your mobile screening unit. First of all, that's excellent.
Yes.
Does that include carriers also, which is also, important for family planning?
It is actually probably mostly carriers. It's mostly trait holders because they typically don't manifest the symptoms.
Right.
I am a sickle cell trait holder. I manifest very few of the symptoms. Typically, if you have the anemia, you are having the seizures
know.
and hospitalizations, et cetera.
Yeah, that's why I asked. Thank you.
Yes.
I don't see any other questions. Thank you. Our next speaker will be Sydney Roberts and a group from Emory. If you'll come to the podium, please.
Thank you, Chair Lady and members of the committee. I also want to thank the Georgia General Assembly. The House and the Senate actually both fully funded this request last year, and it was cut out during conference committee. So we are back again, asking for $1.5 million in state funds to expand Medicaid coverage for adult heart and lung transplants. This would bring down $3 million from the federal government. We are one of 3 states that do not offer this type of coverage for adult heart and lung transplants, and of those 3 states, we are the only one with a transplant center. You have a one-pager as well as a coalition letter of support in your folders, but from there I'm going to turn it over. We have Dr. Sarah DeCaro, who is the Chief Medical Officer at Emory EUH, Megan Shaw, who is the Senior VP of Transplants, and then Dr. Annie Van Buren, who is our Medical Director of Heart Transplants.
Thank you all so much for having us here today. Again, I'm Dr. Van Buren. I'm a transplant cardiologist, and I'm the Medical Director of the Heart Transplant Program at Emory, but really here on behalf of the transplant community statewide, which includes our colleagues at Piedmont. As Sydney mentioned, we're the only state in the country that does not provide, that our Medicaid program does not provide transplant coverage for adult patients. And this translates into a tremendous effect on patients, caregivers, doctors, nurses, and hospital systems statewide. As part of my clinical role, I field phone calls weekly from doctors all over the state, in Savannah, in Columbus, in Rome, in Albany, and all sorts of communities, including here in Atlanta, asking for assistance for patients with end-stage heart failure. For patients who have no other options and who've reached the end of the line in terms of their heart failure, transplant is an indicated and life-saving procedure that ultimately reduces the cost of care for patients and the health systems. Advanced heart failure is a tremendously burdensome disease on patients and healthcare system, resulting in frequent readmissions, frequent contact with the healthcare system, and ultimately an extremely expensive disease. Transplant provides, again, a life-saving treatment for these patients with excellent outcomes. And it's important to note that between Emory and Piedmont, we combined perform more transplants than any other program in the country. We have robust infrastructure to unburden our local communities and hospitals and provide life-saving care to patients. So we're asking for your support today. Again, the $1.5 million, which will pull down an additional $3 million from the federal government to support our patients, support hospitals, doctors, and communities throughout the state. Thanks, and we're happy to answer any questions from the committee.
Yes, you have a question. Leader Hughley?
Thank you, Madam Chair. It's just a quick comment. My brother-in-law received a heart transplant at Emory a couple of years ago, and it's tremendous what a difference it has made in his quality of life. So I appreciate what you do, and I understand how important this is.
Thank you.
Are there any other questions from the committee? I see none. Thank you very much for your presentation.
Thank you so much for your time.
Next would be Dr. Gaylord Lopez.
Good afternoon, Madam Chair and committee members. My name is Gaylord Lopez. I am the Executive Director of the Georgia Poison Center. I'm a PharmD by education and a board-certified toxicologist as a specialty. I've served in this capacity since 1988, and so I'm starting my 38th year as director. And alongside my medical director, Dr. Brent Morgan, we are seeking consideration for additional funding for the Georgia Poison Center. Since 1970, that's over 55 years now, the Georgia Poison Center has operated a poison emergency hotline providing critical treatment advice to both the general public and healthcare providers. From Young Harris to Valdosta, the second busiest poison center in the country has provided these services free of charge to all Georgians, regardless of their ability to pay, every hour of the day, every day of the week. The additional funds we are seeking will allow us to continue to respond to mothers who have 2-year-olds who bite into Tide Pods, to take care of that 18-year-old patient who was bitten by a copperhead while mowing the lawn, and to even provide advice for that 32-year-old addict seeking treatment for an opioid use disorder. If you recall, a few years back, the Poison Center was instrumental in identifying and first alerted authorities about the counterfeit Percocet we had in Middle Georgia, in the Macon area. And it was our highly trained staff of nurses, pharmacists, and physicians who played an instrumental role in identifying this life-threatening event, and they were there to provide reassurance and treatment advice to the doctors, the nurses, the general public, and to law enforcement who sought our consultation. While it's clear that Poison Centers save lives, another important fact is that Poison Centers save money, lots of money. A recent published report by the RAND Corporation, just published last month, confirmed that for every dollar spent on Poison Center services, $16.77, nearly $17, is saved in avoidable healthcare cost. And so when you look at preventing unnecessary emergency room visits, to cutting the length of stay in the hospital, to providing targeted treatment recommendations, the value of the Poison Center delivers is tremendous. And add to this, because the Georgia Poison Center state line item is eligible for federal matching funds at approximately a 3-to-1 ratio, every dollar invested by the state generates a 3-fold return in federal support. This makes the Georgia Poison Center one of the most cost-effective public health investments in the state's portfolio. When we incorporate the findings from the RAND study, Georgia potentially avoids over $100 million in healthcare costs alone. What an incredible return on investment. Now, over the past 5 years, funding for the center has remained flat. We're trying to avoid cutting services that Georgians depend on. The funds we're seeking now are to help us maintain the programs we are now delivering, keep wait times low, and keep calls from being abandoned due to lack of staff. Additionally, these funds will offset costs related to personnel and advancements in communication technology. We are asking that the state of Georgia further invest in the Georgia Poison Center, and with new and emerging trends like THC gummies, kratom, and other novel drugs of abuse, the Georgia Poison Center wants to continue to keep people safe and healthy. Madam Chair, that's all I have. I'm open to questions.
Thank you, Doctor, for sharing that with us, and thank you for what you do. I come from a rural area which has your number on speed dial. So
We appreciate
it's one
that.
of those things when we have lots of snake bites, and you're always there for us. We appreciate it. Are there any questions from the committee? Yes. Chairman Stevens?
Question is regarding kratom. How much of that do you see now?
Our kratom volume has increased dramatically, and I've been partnering with Representative Townsend on this matter and trying to reduce the access to kratom. When we were successful in putting more restrictions on kratom last year, if you remember in January, our call volume increased despite the new regulations that we put on kratom. And so, as you know, this is a very dangerous compound, and we're really trying to shoot for making this one of those Scheduled 1 type medications because it is hurting Georgians, killing them in some cases.
At the very least, stick them as a class 5 or something so that they go less access to the public.
Absolutely, sir.
Representative Buckner?
I feel like you've saved the lives of several people I've known. I live out in the country, and they've played and done things they probably shouldn't have, and y'all were there, and I appreciate it. What I'm interested in knowing is, I know you're interested in having an increase so you can hold on to your staff, but equipment-wise, is there a need for, I thought I had heard that there was a need for some new equipment for you to use.
Yes, great comment. We're trying to enhance our communications technology area, and we've been using the same telecommunication package for the last 20 years. And so it's in dire need of an upgrade, and those cloud-based systems don't come cheap. So we're definitely looking at that, as well as you said, personnel. One of the other programs that you're aware of that is on the cutting board, and Georgians really depend on this service, and that's our animal bite service. It's our rabies program. And when I do lectures around the state and I talk about rabies, here's the thing. I tell them, if you get bitten by a rabid animal and you start having symptoms, there's only about 100% chance you're going to die. Only about 100. And Georgia Poison Center provides that treatment recommendation on whether or not someone requires the vaccines. Now keep in mind, just because there's an antidote or a vaccine doesn't mean everyone who gets bitten gets the vaccine. And so you have highly trained specialists who are equipped and following protocols to decide who is at most risk for developing disease and who are those folks who don't need these vaccines because they're quite costly if you remember.
So is there a proposal of what you need, how much money you need for what?
Yeah, so we provided a breakdown of the various funds that we need. We're seeking $560,000, mainly for personnel, keeping our rabies program open, and then some technology upgrades that you were referring to.
I just missed it, so thank you. I'll look for it.
Okay.
Chairman Petrie?
Madam Chair, and I didn't have a document on this. You just alluded to one, so that may be on there. Doctor, thank you for what you do. How many calls annually are you fielding there, and how many staff currently do we have working at the call center?
In and out of the Poison Center go over 100,000 calls a year. As I mentioned, that makes us the second busiest poison center in the country. The first actually cheats. They are a center that runs 5 states, and I run the poison center here in Georgia, and we only have one poison center. And so we have approximately 18 FTEs in clinical staff that run the hotline. And at our high point, we were at 22 staff, and with flat funding over the years, we've had to reduce staff just to stay within budget, which creates longer wait times and drop calls. And this is one of those 911 services that you don't want to be waiting, and you need immediate therapy. And what I tell people is, look, you could go to Dr. Google and follow an algorithm, but wouldn't you rather talk to a healthcare professional like a doctor or a nurse who could give you this advice instantaneously and free of charge? We want to continue that.
Thank you. Are there any questions? I see no other questions. Thank you very much
Thanks,
for your
Madam Chair. Thank you.
presentation. Chairman Scott Hilton, if you'll come to the podium.
Thank you, Madam Chair, members of the committee. You have to bear with me. In 6 years down here, this is my first appropriations request, so I'm learning as I go here. And I have a new appreciation for what you guys do. I am bringing this request today on behalf of my good friends and constituents, Ashley and Brandon Waters. This request is for the amount of $374,750 to provide for important tools for families suffering prenatal loss here in Georgia. This is to help fund the enabling legislation, House Bill 1250, the Daniel Waters Act. Ashley Waters, Daniel's mom, wrote a note, and I'm just going to read a few lines from that to help inform the committee what it is we're asking for. In April of 2023, the Waters family experienced the death of their son, Daniel, who was born unexpectedly, stillborn, just 1 week before his due date. The hospital where they delivered did not at the time have a cooling unit. Since there was none available, they were only able to spend 9 hours with their son, 9 precious hours to memorize his features, take photos that they will treasure forever. And those 9 hours, those short hours, they were forced to make decisions that no parent should have to make while in the midst of shock and grief. We had to decide based on how quickly his body was changing, the final resting place, and some very important details that were very difficult to make. Families who do have access to a cooling cradle can choose to spend up to a few days with their baby. Simply put, a cooling unit gives families time to slow down, time to read with them, time to say goodbye without rushing. It gives them a peace of mind back. At the heart of this bill, it's the gift of time. Georgia sees nearly 1,000 stillbirths a year. That's 1,000 families leaving the hospital without their baby. The Daniel Waters Act will ensure that every hospital has access to this equipment so that every family experiencing stillbirth or neonatal loss can choose the time that they wish. So what we're trying to accomplish here is to provide DPH with the funds necessary to equip hospitals with what's called a cooling cradle. This is a cradle that, as it sounds, cools the body. It gives families time to grieve and mourn the loss of their child. So I believe a very worthwhile cause. DPH has been a great partner with us and is supportive of the legislation.
Are there any questions? I don't see any. Thank you very
Thank
much.
you, Madam Chair.
I'm sorry.
Thank
Peter
you,
Hughley.
Thank you, Madam Chair. To Representative Hilton. So you said that the cooling cradle will allow the family to stay together for up to 48 hours, did you say?
Yes, ma'am.
So are they still being charged for hospital stay during that time, or how does that work?
I think it coincides with the stay that they're already there. I know when we had our children, we were there a day or two, and so yeah, it's during that time. And what the cooling cradle does is slow the decomposition process, and so they can more respectfully mourn the loss of their child. The cooling cradle, our estimates, there's about 50 hospitals that would need one, and they range from $5,000 to $7,000, which is roughly how we get to that number. You really need only about one per hospital, and it's a relatively, affordable machine. And fortunately, there's a number of vendors out there that provide this, so we're not limited to one vendor. Yep.
Thank you. I don't see any other questions. Thank you
Madam
again
Chair.
very much. We appreciate it.
Thank you.
Our next presenter will be Diana Cortina.
Good afternoon, Chair Lady and members of the committee. My name is Diana Cortina, and I'm the director for Grady's Trauma Recovery Center, and I am grateful for the opportunity to be here with you all today. The Trauma Recovery Center is a hospital-based program that provides free mental health services and intensive case management services to survivors of violent crimes. We serve individuals aged 5 and older who've experienced sexual assault, domestic violence, motor vehicle collisions, child abuse, and other serious violent injuries. Our team works with patients while they're hospitalized, often meeting with them while they're at bedside, and then continues care long after they've been discharged, helping them heal, stabilize, and rebuild their lives. Without sustainable state funding, this proven program is at risk of disappearing. Grady's Trauma Recovery Center is the only trauma recovery center operating in the state of Georgia. Despite strong outcomes, this program is entirely grant funded, and those funding streams are disappearing. FOCA dollars have increasingly been reduced, and ARPA dollars are sunsetting this September. Without state investment, this life-saving program is at risk of shutting down. We are requesting a $1.5 million line item budget from the Department of Public Health to sustain operations. These funds would support staff salaries and allow us to continue providing free services that prevent re-injury, reduce repeat hospitalizations, and lower long-term public costs. This investment works. Without comprehensive care, survivors of violent crimes are often far more likely to fall into cycles of re-injury, requiring repeated state-funded services. Our re-injury rate is only 2.4%, well below the average across the nation. We often see survivors return to work, stabilize their families, and re-engage as productive members of their communities. The Trauma Recovery Center is a data-driven, cost-effective investment that protects public safety and reduces future costs while helping Georgians recover and rebuild. Thank you so much for your time and consideration, and I'm available for questions.
Are there any questions from the committee? I see none. Thank you very much for your presentation. Next will be Morgan McLemore.
Well, thank you, committee. I'm Morgan McLemore. I'm the medical director of the Georgia Comprehensive Sickle Cell Clinic at Grady Hospital. And we are requesting additional funding for our center over and above what we have been receiving, thankfully, from the state since the early 80s. The reason for this is we've had an exceptional growth in number of patients that we serve in this clinic. 10 years ago, we followed approximately 800 adults in this clinic. We are now following over 1,600. This is due to people moving to Georgia. Everybody wants to move to Atlanta. In addition, we continue to get increased numbers of referrals from our pediatric colleagues as they turn 18, over 100 a year. In addition to the patients that we are seeing in clinic, we are also seeing increased volume. We have a dedicated emergency room for sickle cell at Grady that is funded in part by the state. The numbers have increased dramatically since the pandemic. Previously, we saw 3,000 visits per year. We're now seeing over 5,000 and probably will see close to 6,000 this year. Inpatient-wise, the number of people that we see inside the hospital, our daily census used to be about 10, now it's about 25. So, and this has been over 10 years that this number has increased dramatically. Most of the funding is for helping coordination of care and physician supports as APPs, nurse coordinators, and so forth. Patients are getting older, sicker. It just requires a lot of coordination. Thank you.
I don't see any questions. Thank you for your information.
Thank y'all.
Thank you. Brent Walker.
Madam Chair, members of the committee, thank you. My name is Brent Walker, and I'm General Counsel for the Medical Association of Georgia, and rising today to offer our support on behalf of MAG and the MAG Foundation for the Safe Haven funding that was referenced in Director Jason Jones' presentation earlier today. And I bring you good news. The funding that was provided this time last year for the Safe Haven program helped us develop a pilot program for rural physicians in the state of Georgia. This has had really tremendous success over the last 5 months that we've begun promoting it in earnest. Just to give a little context, we have a handout that was in your packet, and we had a couple of slides which I'll forego just to hit the highlights. Physician burnout is a major issue. We're well aware of the physician shortage in the state, but while we pay attention to trying to solve that particular issue, we have to pay attention to our existing practitioners, particularly in rural areas where they're most vulnerable and in the communities that can least afford to lose these practitioners. in various studies we've conducted, we recognize that for a hospital or a large practice, it can cost between $500,000 and $2 million to replace a physician, and that process can take up to 14 months. And symptoms of burnout impact practice. We see that there's a 200% almost increased rate in the risks of medical errors when physicians are suffering from stress and burnout. So the Safe Haven program was devised by Georgia, working in conjunction with other states through the American Medical Association. The first state was Virginia that launched a program like this and had enabling legislation. Georgia was second. We should be very proud because the legislation passed through this General Assembly with your assistance became the model legislation for the country for these programs. What we saw, the design of the program, and one of the reasons we had to pass legislation was we found that there's very low engagement for things like employer-sponsored programs for health and well-being. I think there's a perception that it makes physicians look weak, or their employers may have an adverse action against them, or it may be discoverable in a lawsuit. So the confidentiality provisions in that bill passed in 2024 were really important in the design. We've really had some tremendous success. Last year, we had a pilot program that we established for rural physicians. And as Jason Jones mentioned, we were able to cover 1,667. I, too, did not like that number, so we rounded it up. Unfortunately, that's not all of our rural physicians. That's only about 1,700 out of 2,700 to 2,800 that are practicing in rural communities across the state of Georgia. But what we see is low engagement. Right now, we've had dramatic engagement with this program. We, in the first couple of months, had all of the licenses handed out and these physicians registered. Since October, we have seen a 53% engagement rate amongst the physicians. That's on your handout, which is far in excess of the typical 1% to 2% that we see with programs like this. That's about 4,161 unique interactions. Out of those, 9%, almost 10% now have engaged regularly with the program for coaching, counseling, wellness advice, and the various things that we offer through this program. And indeed, in speaking with our vendors that provide the behavioral health services, we have almost 75 physicians in regular counseling because of the stress that they found in their job, whether it's losing a patient, having adverse outcomes in the operating rooms or wherever. And word has really spread. You know, we've built this framework and we've continued to refine it. While word got out about this program, we had physicians call the MAG office that have lost patients and wanted to gain access. And one of the refinements that we developed with our partners was a physician crisis hotline that's available to Safe Haven participants and non-Safe Haven participant physicians, which has had some pretty dramatic success in drawing people in and helping keep them in practice across the state. This has been a very valuable learning experience. The Safe Haven program really, we're refining how we work with, say, the PHP, the Physician Health Program. What I kind of like to tell people is that Safe Haven is the prevention to PHP's cure. The more physicians we can keep practicing and prevent them from substance abuse issues or other problematic mental health issues that take them out of practice, the better we are together. And we're beginning to work in discussion with them about how to better collaborate to build a very robust framework and how eventually we can expand it. So to follow on to Director Jones's ask, we are encouraging the committee to support a new sustained funding in fiscal year 2027 of $500,000, the same as last year, for us to continue to grow and refine this program and eventually expand it. It is developed to support other allied healthcare professionals, and I think that's a very interesting topic. So with that, the hour is getting late. I have always wanted to say that, but I am prepared to answer any questions.
I don't see any questions. We appreciate what you're doing and how it is reaching our physicians and practitioners. So thank you very much. We appreciate it.
Thank you, Madam Chair, members of the committee.
Next will be Dr. Santos and the Archibald Group.
See if I can, let's see. I'm just going to use this as a guide, but I'll be quick. Thank you, Madam Chair Lady, and thank you, committee members. I'm Let's see. Here we go. Thanks, Morgan. I'm a nephrologist from Thomasville, Georgia. For those of you that may not know this, I had the privilege of testifying a couple of weeks ago. I'm accompanied by one of our interventional cardiologists and the head of our interventional cardiology lab at Archbold, and I'm also accompanied by our fearless leader, Savannah McGowan, who is over medical education in Thomasville, Georgia. Thomasville, small town near Tallahassee, Florida, southwest Georgia, and I just wanted to give you guys an idea of how much you've meant to us in the way you've supported us. We're now on our 4th year with our residency program, and this is a slide that I just show because we had the privilege of Dean Hess speaking to our foundation, and he started out his talk by showing us the shortage that I know that all of you here are very aware of. As a result, at Archbold, we've taken the bull by the horns, and we're committed to not only training graduate medical education residents, but also medical students. And this past January, we started with 6 medical students from MCG, and that's set to grow. We've also had students from PCOM and from FSU, which will continue to be 3rd and 4th year students learning in our facility. We've had the privilege also to being affiliated from a medical education standpoint in partnership with MCG. We're very proud of that and proud of the fact that they are extending their southwest campus down to Thomasville. As a result, the expansion is going to include medical students 3rd and 4th year, and our future looks bright. We started out with 6. We hope to have 24 total soon. Medical College of Georgia's mission statement is one that we embrace, and I won't read the whole thing at this time. Our goal as a clinical campus, of course, will be to sponsor and mentor students in internal medicine, family medicine, general surgery, psychiatry, pediatrics, OBGYN, neurology, and emergency medicine, and we look forward to that. As far as our graduate medical education program, we are affiliated now with MCG, which has been a great feather on our cap. We started out in January 22 with y'all's help with 15 residents total spots, and we received the complement increase now for this year. So starting this year, we are set. This is our first class where we have a total of 8 residents. So we have the fortune to be producing 8 internal medicine residents a year to help with our workforce shortage. And this is the receipt of the help that you all have provided for us. And again, we thank you. These are graduating this year and all going to do fellowships. And we're very grateful that most of them are from Georgia, all except one, and most of them will be coming back to the area to serve as subspecialists. Our future, which we consider bright in education, will include, hopefully, a cardiology fellowship, which will be led by Dr. Sizemore, who is currently my associate program director, the associate program director of our internal medicine residency. Our barrier for that is a cardiac surgery program, which we definitely are looking forward to. We also hope to have a gastroenterology fellowship, both 2 very needed subspecialties. The gastroenterology fellowship would be shared by other hospitals in our surrounding area.
Thanks, Riley. So he asked me to share with you. He kind of went over real quickly with you what we're doing, and I'm going to take literally 2 minutes to share with you the why. Cardiovascular, and it's going to be slanted obviously with my bias towards cardiovascular, but you could substitute probably any specialty in there and find similar numbers. The American College of Cardiology has had several recent publications in the last year or 2 documenting the disparities between rural care and metropolitan care. It's pretty dramatic. I'll let you look at the slides later, but again, you see a concentration of the higher death rate counties in rural South Georgia, and so that's why we think that this program is so important. And it really comes down to access, even when you correct for all the demographic issues, whether it be race or socioeconomic class. It really has to do with access and where you live. And we just feel real strongly that your zip code shouldn't dictate your likelihood of dying of cardiovascular disease prematurely. And so at the heart of the problem really is this slide. If you don't look at any other ones, look at this one. You'll see that we have approximately 1,200, just shy of 1,200 fellows coming out every year in cardiology. And that sounds okay, except for the fact that you look 2 lines above and you realize that 1,600 are retiring. So that's a net deficit year over year of almost 450 cardiologists. So we're moving in the wrong direction. And so in particular, when you think about Georgia, we have 4 cardiology fellowships. There are 29 cardiology fellowships in Florida. So they are roughly double our population, but they have 7 times more cardiology fellowships. So there is a fairly desperate need for the GME efforts that you guys have all been making, and we do deeply appreciate and have enjoyed sitting and listening to all the efforts that are going into rural GME and medical education in general. So as part of that, we have been asked, because of our early success with the residency program, to talk about doing a cardiology fellowship, and we quickly realized that in order to do that right, we needed to have a surgery program. Our patients are currently going across state lines to get CT surgery anyways, and so I'm happy to report, successfully submitted a very ambitious or I think very strong application for CON for South Georgia CT surgery in our what we think is very much rapidly evolving academic community hospital. So anyways, we'll get to the ask. Obviously, we would just applaud your efforts in trying to help us staff up our rural communities with all specialties, and hope we can afford your support with regard to our attempts to create a regional cardiovascular center of excellence so we can increase the number of fellowships. And I'll turn it back over to Raleigh, I think, for our kind of specifics on the ask.
And so we've had the fortune that our hospital has recently purchased a campus, a college campus, and this is the Smith Bonvillian building, which is a building that's going to be dedicated in Thomasville, Georgia, specifically for medical education. And it's going to be undergraduate, graduate medical education, and also nursing, advanced practitioners, CNAs. The building is a building that will need to be renovated, where the renovations are set to start in July. The ask is going to be for help with simulation, the auditorium, restructuring, classroom, conference space, and office space. We really believe the future will be bright. The campus is large, so it will help us with housing kids that are looking to go into medical education. So with that said, we asked for the help with the renovations, $1.8 million. And once again, I would like to thank you for everything that you've done. It's hard to believe that we're now 4 years into strong education in our area, but I think that we're really making a difference. Thank you.
Thank you. Are there any questions from the committee? I don't see any. Thank you very much. We appreciate your presentation and what you do. Our next presenter will be Amy Hughes.
Good afternoon, Madam Chair and committee members. Y'all will recall, I'm Amy Hughes with Hughes Public Affairs from Savannah. I represent Hospice Savannah and PACE Georgia, which is their PACE program. You'll recall when Representative Petrie introduced the Program for All-Inclusive Care for the Elderly in 2024, and y'all passed that legislation overwhelmingly because of what it's going to do for our seniors. Well, last Friday, DCH granted PACE Georgia, Hospice Savannah, the first PACE program for Georgia. It's going to cover Chatham County. It's going to cover about 18 zip codes in Chatham, and hopefully it'll get to expand around coastal Georgia as well. So we're just very, very pleased about that. One of the really important components of a PACE program is a transportation network. because you have to be able to get the members and take them to the PACE Center and take them to the doctor's appointments and take them to the grocery store and provide them all the services that they need to have in order to live independently at home and stay at home as long as they possibly can. So it's a really critical component, but it's also a very expensive component. Now, I'm also thrilled to announce that last week we found out we've got $295,000 for PACE Georgia, our Savannah hospice program, in the federal budget for this purpose. And we also got another grant of $85,000 from Gulfstream. So as a nonprofit, we're working really hard to raise money to support this program. Lots of other donations as well from private individuals and foundations locally. But the problem is that transportation component cost about $5.4 million just for that first 3 years of operation and to stand it up. Just because of all the different costs with the vehicles and the staffing and the insurance and all those things. And as you know, this is a program that doesn't make money until at least year 4. So it's a big lift to subsidize that. This committee was very generous in 2024, and if you remember, you came up with some grant money for DCH, and DCH provided grants that were planning grants to help the people plan for PACE programs. And I will tell you that we were ready to apply and had our facility renovated and all that, and that's the reason that we were selected as one of the first programs, because of that grant funding. What I'd ask you to consider for this budget is a similar type of grant program for DCH to administer as new programs come online and based on need, that they could grant out funds in a similar way. Last time it was $500,000 that they granted out to 3 providers. So, but thank you very much. I appreciate it. This is going to be a real game changer for Georgia's elderly, and we're thrilled to be part of it.
Thank you very much for your presentation. I don't see any questions. Thank you. Next would be Jet Tony.
Madam Chair and members of the committee, Jet Tony representing the Georgia Academy of Nutrition and Dietetics. This third year request for $281,000 to fund medical nutrition therapy in Medicaid for adults. Currently, pediatric patients are the licensed dietitians who are providing medical nutrition therapy to pediatricians are reimbursed, and those licensed dietitians are able to bill independently. So the request is twofold. It is to Georgia Medicaid adjust the CPT code so that dietitians can bill independently under the Diagnostic Screening and Preventive Services Program. This will increase access to medical nutrition therapy throughout the state, especially given the wonderful technology that dietitians are now using through telehealth. In fact, the presenter that was to appear today provides telehealth services to patients throughout the state, but she had an add-on appointment for a patient that needed her help today. The second ask with this is to change the fee schedule and establish the children's intervention. Can Georgia Medicaid follow the fee schedule established with the Children's Interventional Services for codes 97802, 97803, and 97804? Medical nutrition therapy is an important part of a team approach to helping patients where the nutrition of the patients can actually make a strong impact on the improvement of patients who are willing to take the advice of the physicians and the licensed dietitians who are creating the improvement plan for the patient. Madam Chair, you had asked me at a meeting we had earlier this year to look at research of what success is occurring in other states, and there are at least half the states are covering adult MNT and pediatric MNT. And the research, it's pretty dense, so I'm not going to go through it, but I'm going to give this to you. The response to that is it's very difficult to judge whether or not a physician's part of the treatment or a dietitian's part of a treatment plan is the sole factor of how a patient, typically with multiple comorbidities, that is, multiple challenges, to determine the outcome and who's responsible for that. But on this chart, again, I will give this to you. It describes what research has shown where the addition of MNT to both adults and pediatrics has had either high, moderate, or low evidence certainty. And that's the way, because each patient is different, it's very difficult to score or to find a definitive answer to that. But I wanted to be true to your request, and this is the best evidence that we have.
Thank you. If you give me that, I'll distribute it to the committee.
Thank you.
Thank you very much. We appreciate it. I see no questions.
Thank you.
Next would be Tyler Riddle.
Good afternoon, Madam Chair, members of the committee. I will be brief. I have an easy one for you today, not asking for any money, so hopefully this will go as quickly as we all want it to. My name is Tyler Riddle. I own a durable medical equipment company in Georgia, MRS Home Care. We have 15 locations in Georgia, and today I'm here representing the Georgia Association of Medical Equipment Suppliers, of which I am the former president. And I come before you to advocate for the Medicaid beneficiaries of Georgia and for Georgia DME companies. I'm here to ask for the committee's support in language in an appropriations bill that sets the Georgia care managed organizations, the Georgia CMOs, rates to 100% of the current Medicaid fee-for-schedule rate floor. Care managed organizations right now are able to pay providers at less than the current Medicaid fee for schedule, and that causes significant access to care issues, as a lot of times those rates are much, much below the current fee for service Medicaid rates. It's a bipartisan issue that many states have already adopted, and by providing parity, this will ensure patient access when beneficiaries transfer from one care managed organization to another. It'll prevent multiple reimbursement rates for the same items and services. And consistent and fair rates are vital to access to care. Under the current structure, patients and physicians struggle to find DME providers under these reduced rates. Since 2013, we have seen a 44% decrease in the number of DME locations in Georgia, with 80 Georgia counties currently not having a DME location within the county borders. And with so few DME locations, any challenges to reimbursement creates instability for this vulnerable patient population. My own company does not contract with 3 of the CMOs because their rates are so far below the Georgia Medicaid fee schedule. And therefore, many patients are forced into much more costly inpatient facilities and care rather than be treated with less costly DME in their home. Additionally, since CMOs are paid by Georgia Medicaid at a capitated rate, them reducing these rates for us is really unfair. There's no reduction in their payments that they're receiving and no savings to the state or benefit to the patient in this. So a really easy ask in that it's a budget neutral net zero proposition. The final piece of this is because there are no significantly large Georgia DME providers. I'm the largest independent provider in the state with 15 locations and about 200 employees. We really don't have any bargaining power with these CMOs, as they are large multi-state companies. My company currently serves around 4,000 active Medicaid beneficiaries right now, and we are just a small fish in these large companies' ponds when it comes to negotiations. So setting this rate floor at 100% of current Medicaid rates would allow smaller independent providers to be competitive and serve Medicaid beneficiaries throughout the state. Thank you so much for your consideration. I hope I was brief, and if you have any questions, I'm willing to take them.
Thank you for your presentation. I don't see any questions from the committee.
Perfect.
Thank you.
Thank you.
Next up will be Laura Bracey. And, okay. Is this Dr. Frankel? That's right. Thank you.
Thank you so much, Chair Lady Taylor, committee members. It's a pleasure to be here. I know it's a long day, and I appreciate your attention and to what I consider to be an extremely important issue for Georgia's citizens. Stroke's a very common disease in Georgia, and the Paul Coverdale Stroke Registry was started 25 years ago. That has been in place until last year. We lost funding from the CDC, so I'm here today asking for support at the level of $500,000 in funding. I started the registry 25 years ago, and currently we have over 100 hospitals that actively participate, which represents about 97% of patients who are admitted to hospitals in Georgia. We actively work together. We share best practices. We have broken down barriers across what you would call competitive entities to share data and work collaboratively to bring hospitals up, small hospitals, medium-sized hospitals, large hospitals, working closely with EMS across the state. The success itself has been measured in many different ways. The Coverdale Registry established this coordinated system of care back in 2001, and the treatment rates for hospitals has really more than tripled. Treatment with drugs like TPA, which are very time dependent. The time to treatment has been nearly cut in half, and hospitals, especially rural hospitals, have seen significant reductions in stroke-related mortality. We know some facts about stroke. Stroke is a common and terrible disease. It is profoundly disabling and deadly. It doesn't care if you're a Republican or a Democrat. In fact, stroke killed the late Senator Paul Coverdale and Speaker Tom Murphy. The good news, though, is that stroke is treatable and preventable, and we've made incredible progress in the past 25 years, driven in large part by the Paul Coverdale Stroke Registry and the participation of the hospitals that I mentioned across Georgia. The loss of funding, though, that occurred last year puts us into jeopardy in terms of what we need to do across Georgia. Even though it's the leading cause of long-term disability in Georgia, the care of patients with stroke doesn't get the support it needs, but we know that every 15 minutes of faster treatment avoids approximately $30,000 in lifetime disability costs. That's profound, and that's what we do with the Coverdale Registry. We work with hospitals to teach them about how to do better with their practice, their workflow, and we track that data and we share that data and we use that to improve care. For every dollar invested in early stroke systems, it saves about $3 to $8 in downstream public spending. And so I strongly believe, as do others around the state, including the American Heart Association, that a $500,000 appropriation is a modest investment that will protect lives and stabilize rural hospitals and reduce the long-term health care costs from this disabling disease. Importantly, the Coverdale Registry is not really it's not a new program. It's not a policy change. It's been in place for 25 years. It's a proven system that already benefits Georgia's citizens who have strokes. What happens if we don't have this legislative action? Well, Georgia risks losing years of progress. Communities with the highest risk populations would suffer the greatest, particularly rural areas. So my hope is that you will consider this request, allow us to continue this amazing program. It's quite unique. There are a number of states around the country that have registries, but they all look to us. They're quite envious of what we've created here, and it's my hope that it will continue on. So thank you very much for your time.
Thank you for what you do in this important cause, and I do not see any questions. Thank you. Next would be Becky Riles and Dr. Ringer.
Thank you, Madam Chair Taylor and members of the committee. It's my pleasure to be with you today. I will be very brief, as we will have the rest of this session to discuss community health centers in much more detail, but I would like to level set with reminding you that community health centers are nonprofit, community-led organizations. They're governed by local leaders, and more than 50% of their board members are patients at the health center. This is by design so that the services provided in that community by that particular health center are meeting the needs of the patients in that community. Georgia's community health centers are medical homes to almost 750,000 patients. There are 36 health center organizations in over 330 clinical sites in Georgia and 145 counties. Patients who are seen at a community health center save money by the costs in the chronic disease management, the community health workers, patient navigators who help patients maintain and learn to thrive with their chronic diseases. Of the 750,000 patients that I mentioned, about 194,000 of those are Medicaid recipients. So 1 in 12 Georgia Medicaid recipients are seen at community health centers. And by data provided to CMS, and then that comes back to Georgia, shows that a patient seen at a health center is a cost of about 33% less than a patient seen by other primary care providers. In total, in 2025, 2.4 million patient visits by your community health centers. We thank you for your support. We have a little different ask this year. I will be glad to stand for questions, but first, I would like for you to hear firsthand from Dr. Dave Ringer, who is literally Georgia grown, MCG graduate, must have received one of the first loan repayment programs to go to a rural area, and so he went to Greene County and has been there ever since. So with that, I would like to hand it off to Dr. Ringer.
Thank you. Thank you, Becky. Thank you, Madam Chairwoman Taylor and the members. I appreciate it. Yes, she took the fun away. I actually was one of the very first, 44 years ago, I got accepted to medical school and got the small town scholarship. It was a brand new thing. Paid for my entire medical school, which was very nice. And then all I had to do was go to a small town for 5 years, and I happened to stay there 37 years. So it's been a great run. I was in solo practice for several years, and we got very lucky to get a federal grant called an FQHC, Federally Qualified Healthcare Center, Community Health. They hadn't released them in several years, and we applied as a community and received it. And I joined in on it and merged my practice with it, and it has just been unbelievable. It is, I just can't tell you how great the community health centers are. To be able to have your patients actually are your boss. Your patients are involved in running the practice. They're on our board. I was placed as CEO several years ago and still see patients. We go to the nursing homes. We go to the hospital. We have great relationships with the hospital. I'm actually chief of staff of the hospital, our local St. Mary's Hospital. And it just all works well. Everybody gets equal care. what so many people think, and you hear when you say, oh, a community health center, that's a free clinic, right? No, it is not a free clinic. It's basically a private practice. I mean, it is run just like it, except we refuse nobody. We take care of everybody that comes, and we get some federal grant money for that. The other thing people think is that we just get, oh, you're federally funded. You're a free clinic. No, only 10% of my budget is from federal funds. So 90% of it is just like any other doctor's office, where we take Medicare, Medicaid, private insurance, and then we base it on a slide if you have no insurance at all. So we're very dependent on Medicaid, and what you'll find out a lot is, and what y'all might not know, because it took me a while to learn this. I actually had to go back to business school because it's very complicated. But Medicaid pays providers when I'm in private practice under the CPT codes, which other people have talked about. But the community health centers, we get a Medicaid payment rate. It's basically a one-time fee. No matter what you do, you get this much money. So if I see you for 5 problems, I'm going to get this much money that day. If I see you for 1 problem, I'm going to get this much money one day. That rate is set by the state, and it hasn't been changed in Georgia for over 10 years. So we're a little bit behind on cost of living, because what typically happens with us is we still have to compete with other states. We have to compete with other areas for doctors, for nurse practitioners, for all the different supplies and support, and things have been going up. So at least 20 to 25% of our practice is Medicaid. So it sounds good on one end when you get this flat fee, instead of, you have to bill for a sore throat, or bill for a heart attack, or bill for this, or you get different amounts. But it basically hurts us in certain areas if that fee doesn't come up some. Dental is a huge area for us. It's very frustrating because I think, I'm a medical doctor, but I think dental is so critical towards the health. And we do a great job at chronic care management, and what you'll find is we keep the patients out of the hospital if they can come see us regularly. But with dental, a lot of times they can't come see us. They have Medicaid. Medicaid plays that flat rate. It doesn't cover all the different areas. So if that rate is elevated some to compete with other states, basically just trying to be equivalent to other southern states, it certainly helps. It will definitely help us provide better care, keeping them out of the hospital. I mean, I've worked the ER many years along with my practice, and people come in with abscessed teeth because they can't see the dentist, because the dentist doesn't take Medicaid, and they can't get in, and they come to the hospital for a much higher cost. They also end up having heart disease. They end up having high blood pressure. Their diabetes goes through the roof, all because of the chronic care management and the way it's paid. So if we can, our ask is just to try to take that rate that hasn't been adjusted in 10 years and just bring it up to what other southern states are doing. We're actually the lowest, I think, in the southeast or whatever. So, and Georgia's never the lowest. We're the best. I would like to say one more thank you. Y'all make a huge difference, and you might not know it, but last year y'all approved $200,000 to open up more sites. I was the recipient of that. Our company was the recipient of that. And we are opening up a new site in Morgan County next month. So it makes a difference, and I really appreciate that.
Thank you very much. We appreciate our FQHCs and what you do. You're reaching and providing medical homes for people that need it. So we really do appreciate it.
Thank you.
Are there any questions? I see no questions. Thank you very much.
Thank you very much.
Next would be Tom Cornegay.
Thank you so much. I guess good evening at this point in time. Name is Tom Cornigan, and I represent the American Society for Gastrointestinal Endoscopy. ASGE is working on a CRC screening project with Community Healthcare Systems, which is an FQHC that cares for 21,000 patients in East Central Georgia. ASGE's ask is for lawmakers in Georgia to budget $916,000 to screen uninsured patients for CRC in rural areas in 2027. We're proud to report that the ASGE project to date has screened 164 uninsured patients for CRC, and we've helped 13 patients who had an abnormal test result achieve peace of mind with a follow-up colonoscopy, and we have 4 more, 4 more pending. ASGE believes that FQHCs like CHCS are a great option to help uninsured patients get screened for follow-up colonoscopy. And given their extensive networks, relationships, and touch points, we would also like to express our sincere thanks to lawmakers for allocating $250,000 in 2026 to screen uninsured patients in rural areas for CRC. Finally, we would like to note that ASGE supports the language in Section 38.33 that directs the Department of Public Health to develop a strategy to promote awareness and prevention measures for CRC and prostate cancer. Thank you. Appreciate it. I'll be pleased
Are there
to
any
take any
questions? I don't see any. Thank you very much for your presentation. Next would be Jill Brazil.
Chairwoman Taylor and members of the subcommittee. My name is Jill Brazel, and I'm the Director of GME Operations at St. Francis in Columbus, Georgia. I want to thank you for the opportunity to speak on behalf of St. Francis Emory's Healthcare's psychiatry residency program. St. Francis Emory Healthcare, if you already know, currently houses 2 residency programs, an internal medicine residency program with 30 residents, and a psychiatry residency program. I am here today to request the full funding for 7 new psychiatry residency positions that are scheduled to begin their training on July 1st, 2026. We understand that 5 of the 7 slots have been funded, and we are asking for the entire support for all 7 slots. The total funding for 7 slots is $176,694.42. The additional amount that has not been funded is $50,484.12. With these positions fully funded, St. Francis Emory Healthcare will train the 28 psychiatry residents at full program capacity. These physicians we expect to stay in the state of Georgia to treat our patients. Our hospital and residency programs have been deeply appreciative of the support you have already provided to us in the past, including funding our state-of-the-art learning center. We would welcome you all to come back and visit anytime. And I thank you today and would be happy to answer any questions from the subcommittee.
Thank you for what you do at St. Francis. It's really important, and I know it's reaching a lot of people. I don't see any questions, and thank you very much for your presentation.
Thank you.
Next would be Cabe Boyan.
Hello, everyone. Thank you for having us today, members of the House Appropriations Health Subcommittee. On behalf of the nearly 11,000 members of the Patient-Centered Physicians Coalition, we thank you for your ongoing support of primary and maternal care practices in Georgia. As you know, primary care provides vital foundations for medical care for many Georgia residents. Physicians in these specialties couldn't do it without the strong support from the General Assembly to strengthen our Medicaid program, specifically primary care reimbursement rates. Small and mid-sized primary care and OBGYN practices continue to face significant financial pressure. Georgia Medicaid has historically reimbursed at rates below Medicare. However, due to your efforts, reimbursement levels have improved over the last 10 years. For the fiscal 2027 budget, we are requesting that CPT codes 99213 and 99214, plus 4 OBGYN codes, be increased to 100% of 2024 Medicare rates. The projected cost to update these codes to 2024 Medicare rates is $19.15 million in state funding. Thank you for considering this request. The support of Georgia's primary care physicians and maternity practices help ensure that Georgia remains strong and maintains the medical and health care foundation so essential to our future. Thank you so much.
Thank you. I don't see any questions. Appreciate it. Thank you. Next would be Helen Sloat.
Hello, good afternoon, Madam Chair, members of the subcommittee. My name is Helen Sloat. I'm with Goldome Partners here in Atlanta, and I'm here to speak to you about some children's issues. First of all, I would want to say we are so appreciative of all the work that you have done to help Georgia's neediest children. So in particular, the first request is on behalf of Easter Seals, North Georgia. Easter Seals is a nonprofit. It's located in Sandy Springs. They have a contract currently with the Department of Public Health to provide the Babies Can't Wait services program for the Gwinnett area. It is the only privatized Babies Can't Wait program in the state. Other areas of the state, those services are provided through the public health departments. Their contract is around $2.53 million. It's been in place since 2018. They are asking for an increase of $250,000 because they have been asked to serve more children, and the cost to provide the services to those children have increased. Those services are things like OT, PT, speech pathology services, those kinds of things. So we would ask respectfully if you could consider the $250,000 increase to the Babies Can't Wait program in the Infant and Child Essential Health Treatment Services program within DPH. The second request I have, excuse me, I sound sort of froggy up here, relates to the psychiatric residential treatment facilities. We represent Together Georgia and Multi-Agency Alliance for Children, and both of those organizations have psychiatric residential treatment facilities that are members. There are only 6 PRTFs in the state. In 2024, there was an increase made to the per diem for those psychiatric residential treatment facilities. And as a reminder that those facilities actually treat the highest level of care for children with mental health issues. The rate in 2024 was increased to $649.22 per day. Since that time, we have seen greater costs, and they have come to us and asked us to advocate for an increase in their per diem to $800 per day. I know you've heard a lot about the cost of the psychiatric residential treatment facilities and the fact that there are not enough beds. We believe that this will help greatly improve that situation. So we would ask you consider raising the per diem to $800 per day for these 6 facilities. And I'm be glad to try to answer some questions, but my people aren't here with me today. But if I don't know the answer, I'll come back and get that for you.
I don't see any questions, and thank you for bringing this information to us.
Sure.
Thank you.
Thank you.
Next would be Cash. Come, we're ready. Are you ready? Okay. Come.
All right, good evening. Chairleader Taylor, members of the committee, thank you for the opportunity to speak today. My name is Kim Dean, and I'm here on behalf of Autism Providers of Georgia. We're a 501c6 organization representing providers operating in more than 100 therapy clinics across the state, serving thousands of Georgia families with children with autism. I'm here to speak in support of a $16.1 million appropriation in the fiscal year 2027 budget to equalize Medicaid reimbursement rates for applied behavior analysis, which is ABA therapy, by bringing clinic-based rates to parity with in-home rates. Georgia is currently an outlier. It's one of only 2 states in the country that pays a premium for in-home ABA services, and in fact, the rates are 20 to 25% higher, depending on the CPT code, for in-clinic as compared to, for in-home as compared to in-clinic. And another way that Georgia is an outlier is that 65% of Georgia's Medicaid ABA spend is for in-home, and that compares with only 15% for the country overall. This difference is driven by reimbursement policy, not medical necessity, and this rate difference has unintentionally created a market distortion, one that incentivizes place of service rather than what's in patients' best interests. Research shows that children receiving ABA in clinic, they master goals more quickly, often twice as quickly, because clinics provide a structured environment, peer interaction, as well as constant clinical supervision. Clinics allow for real-time treatment adjustments, social skill development, and greater intensity of services. Clinics typically have licensed professionals on staff at all times, while in-home care is primarily delivered by frontline workers with oversight from licensed providers via telehealth. Many children in clinics have a shorter overall duration of care and better long-term outcomes as a result. And the financial implications to the state are significant. In-center models are estimated to generate more than $200,000 in direct lifetime Medicaid savings per full-time child. And early intensive clinic-based intervention, which is difficult to achieve in home, is estimated to yield $1.7 million per child in total lifetime savings costs between healthcare, special education, and lost productivity, among others. And furthermore, because of the intensive nature of early intervention, it's just exceedingly difficult to accomplish the same objective in home. Yet today, unfortunately, these services that are most likely to generate these savings receive the lowest reimbursement and have the highest operating costs. This budgetary request would not discourage in-home services, and in fact, in-home ABA is medically appropriate and necessary for many children, but Georgia should not incentivize one setting over another due to rates rather than medical necessity. Equalizing rates will expand access to high-quality clinic-based care, particularly in rural and underserved areas. It will allow providers to hire and retain staff, reduce wait lists, open additional centers, and allow parents of children with autism to effectively participate in the workforce rather than being homebound. And most importantly, it will ensure that care decisions are driven by the needs of the child, not by payment disparities. This targeted $16.1 million investment aligns reimbursement with outcomes, improves access for Georgia families, and reduces long-term state costs. This is a smart fiscal decision and a meaningful step forward for Georgia's children and taxpayers. Thank you for your consideration, and I'd be happy to answer any questions.
I don't see any questions. Oh, I'm sorry. Yes, Chairman Petrie.
Thank you, Madam Chair. Sir, explain to me the disparity between the home-based autism services and the clinic-based, because I have clinics in my community and I've heard this to be an issue. So can you help explain to me in more specific numbers the disparity in reimbursement with those 2 services?
Sure. So, sorry, can you repeat that?
Per unit, if you
Per unit, yeah. So there are roughly 8 reimbursement CPT codes that we bill, and depending on the code, the rate difference based on place of service is between 20 and 25% greater for services rendered in-home. And at the low end, the direct care rate, 97153, the difference is 20%. And for some of the clinical supervisor rates, the difference is as high as 25%.
Thank you. Thank you very much.
Are there any other questions? I don't see any. Thank you very much for your presentation.
Thank you.
We'll say, Cash, do you want to add anything to this? Thank you. We appreciate that. Robin with the PHP.
Good afternoon, and I know it's a long day. Thank you, thank you, thank you. My name is Robin McCown. I'm the Executive Director of Georgia PHP. We are the physician health program for the state of Georgia. We do that via contract with the Georgia Composite Medical Board and the Georgia Board of Veterinary Medicine. We are not a wellness program. We're not a licensing board. We work with those providers that have an illness, a diagnosable condition that might have reached into some issue of potential impairment, whether it's a substance use disorder or whether it's a bipolar depression or whether it's a significant any other mental health condition that really requires chronic disease management. So we're a little different. Our folks stay with us for a period of time. You guys provided us with funding last year, and I am here to tell you how grateful I am. Physician health has been a lifelong work for me, for my family, for my career for 35 years. And the efforts of what this funding did for us and the enhancements of what we're able to do. We've had a 40% increase, and this isn't just people accessing our services. This is physicians primarily that are seeking care. They're going into treatment. They're restoring their health and wellness. They are returning to practice. They're following a pathway to do it safely and protecting the public. And all of this is being done in a confidential manner where it's not reported to the Georgia Composite Medical Board or the Georgia Board of Veterinary Medicine. Now, there are times that does need to happen, but we're life-saving, and you have helped us to be able to do this. And we have provided over $65,000 in scholarships to primarily physicians that have had hardships because they had to remove themselves from practice. This illness doesn't discriminate between rural and metro Atlanta. It is across the board. And again, thank you. Thank you.
Thank you for what you do. We are investing a lot in growing doctors and getting doctors, and if we can give them a helping hand once we have them, this is wonderful. And thank you for what you do.
Thank you for what you do.
Thank you. I don't see any questions. And I will ask, I think this is my completed list. Is there anyone that wanted to speak that has not had that opportunity? I'm very grateful for each of you that have stayed this afternoon and helped us to be able to listen and hear the needs among the people of the state of Georgia. Thank you, and with that, we are adjourned.